Cecil Ryan is my name. I'm here to talk about hand hygiene. A disclaimer to start with, I'm neither a microbiologist or a clinician. I am somebody who spends pretty much most of my working life talking to people about hand hygiene in various different countries and different types of organisations around the world. So what I've come to share, hopefully, is a bit of insight into what is happening around hand hygiene, and it might actually make you feel better about your own efforts in hand hygiene in your various organisations. So, WHO, lots of different posters, lots of different messages, but one very fundamental message, which is that clean hands save lives. And something that is very simple and has such a high impact and has been promoted for so long still remains difficult to achieve. So, I have a pretty simple phrase: how hard can it be? But actually it is very hard in lots of very sophisticated organisations in lots of very sophisticated countries around the world. So everybody here knows, and I'm not going to preach to you, that it's a key factor in infection prevention. Everybody agrees just how important hand hygiene is. Everybody pretty much agrees what the steps needed to be done are. There's a fair amount of agreement on how to go about it. And still, there's almost universal failure to achieve consistently high standards of hand hygiene. And that's across acute hospitals, care homes, developing countries, incredibly wealthy economies. But it's changing. So just to, I suppose, support what I say and maybe make some of you guys feel better about yourselves in terms of some of the numbers. There was a study published last year, and it was a review of 57 other studies on hand hygiene compliance in healthcare settings. And the baseline for all the studies when they started with their various interventions was 41% compliance with hand hygiene. I don't know if there's any other place in healthcare where 41% would be even dreamt as being acceptable. And after the various interventions, that rose to a mean base of 67%. Sounds like a big improvement, but still represents 33% non-compliance. A couple of factors come out of that study. In almost all of the studies, there was higher compliance with the moment after patient contact. And there was a little inference that people were concerned about their own welfare, and they would wash their hands after patient contact rather than necessarily before. All but one of the 57 studies had improved compliance levels after whatever interventions they did. And you'll all have heard of the multimodal strategy for improving hand hygiene, but even single type interventions had some impact. So anything that people do helps. Second study, by coincidence, happened not very long before the pandemic. And during the intervention, they didn't measure pre-intervention, but during the intervention, they had 58% compliance. That dropped to 46% post their intervention and pre the pandemic, and dropped to 34% during the pandemic. Now, there was lots of reasons why that's A, crazy, but B, understandable. Slight detour, but on PPE, we did a study around use of PPE in hospitals, and what the nurses were saying back to us was just the time pressure of getting, need to go to a patient, the buzzer goes, you've got to find the right PPE, you're supposed to find a buddy to check that your PPE is on correctly, trying to find a buddy, the buzzer goes again, eventually the patient opens the room, comes out, and it's a car crash. So people are under time pressure. People don't do this stuff deliberately. They don't deliberately fail. So I've used the word compliance a few times now. And generally when people talk about compliance in hand hygiene and healthcare, they're talking about the 5 moments or the when. But the technique and the way that you wash your hands also matters. So this number now gets a little more scary. Really, you need to take the quantity compliance and put it against the quality compliance to get your effective compliance rate. And if you take 40 to 80% as being quantity, and 80% would be pretty exceptional, and you take a 15 to 18% compliance rate with technique, And that's backed up by a number of studies. Multiply them out, you've now got a 6 to 14% compliance rate. So if any of you guys were feeling bad before you came here about the compliance rate in your organizations and thinking that you were maybe out on a limb somewhere, you're not alone, but there is changes coming. So what I just want to talk about a little is what I call the hand hygiene quadrant, which is the 4 areas of hand hygiene. So there's the how you wash your hands, which we'll talk about the different methods in a moment, but ostensibly the WHO method. The when, which 5 moments, and I know there's variations for care homes. How well, and the ways of checking how well somebody has washed their hands in an immediate situation are pretty limited. And the what with, which is the soap and gel manufacturers and all the various advancements that are coming from their direction. But in that, and increasingly, and really increasingly, and particularly post-COVID, is reporting, is being able to demonstrate to outside agencies what has been done and having metrics to support it. And there is another piece, there's an old management phrase of what you can measure, you can manage. And having an easy way to know what is happening tells you where you can direct your efforts. So if we talk about the how, so you'll notice that on this we don't have wrists. Well, that's the WHO poster, and we call it the gold standard for your hand washing technique. And I think most people have seen this, most people have exposure to it. But what actually happens is there's different variations of order. So some countries do fingertips first. Some countries have extra poses. So I know that Luxembourg has an extra pose to cover this area, because if you do see sometimes on UV boxes, people do miss this area. It's my weakness when I get tested. But the key is friction on all surfaces, and UV boxes sometimes only measure coverage of gel, but there does also have to be friction in the hand hygiene piece. And I was really interested to say the paper, I think it's your paper from Birmingham, has the most commonly missed areas. So our own Surewash training system does north of 1 million training sessions a year, and really strong correlation. The missed areas are where people struggle with: thumbs, fingertips, and wrists. We had one of our units in the States, and a TV show came on, and they spoke to 2 experienced healthcare workers and said, "How do you find this?" And they said, "I never knew I had to wash my thumbs." Live on NBC News. And the second person says, "I didn't quite know that was how you had to wash your fingertips." So it's everywhere. And it's a difficult thing to teach. So why is it so hard for people to do something that in theory should be so simple? We all get up every morning and tie our shoelaces pretty much the same way, and they don't open during the day because we've generally done it properly. So this is feedback as I've talked to people around the world about what challenges they see, mostly infection control officers, the challenges they face with their own colleagues. It's a bit dull. So when you come in and you get told you're going to be taught to suture or to do some really complicated process, that's exciting, there's a buzz. Today's Learn How to Wash Your Hands Day doesn't really set people on fire. It is difficult to teach, and I'll talk a little bit more about that in a minute, because it's a psychomotor skill, and it's not really something you can teach in one go. It's hard to measure. And you have manual observation is kind of the main way that it's measured, somebody's technique. That's pretty tricky, for example, if you've a lot of single room occupancy. You have to send somebody in to watch somebody wash their hands or apply gel before they go to the patient. It's time consuming. So, when you multiply the number of times a day that somebody needs to apply gel or wash their hands, back to the rush piece, it takes a bit of time. And then you've habits. I was with a community infection control officer last week, and she sort of said, well, we have people who wash their hands a different way, but they've always done it that way, and it's pretty good. So we've decided, and I actually understand where she was coming from, we've decided trying to change those people is less payback for us than getting somebody who doesn't do it at all to start to do it properly. I don't know if laziness comes into it. I don't know if people sometimes, and bear in mind, we're not always just talking about healthcare workers here. You know, there are people, contractors, catering staff, facilities management staff who are in and out of hospitals who also have to wash their hands. And I think particularly with some of those folks, understanding the importance isn't always there. So healthcare workers get told about it a lot. Other folks get told about it. I'm not certain, and it's a generalisation that it's as big a deal. So I used to, in a previous life, be involved in a company which sent people in and out of hospitals all day and sent them from hospital to hospital, which if you think is quite scary. And I remember talking to a hospital and they said, no, we insist all the people that come in and out are trained in hand hygiene. And they weren't. They at no point had training on hand hygiene. And they were going from hospital A to hospital B on a route system and going in and out of washrooms. So there is challenges. So one of the things that's come out of those challenges is people have said, this is just too hard. We can't get people to do our 6-step technique. So there's been a fair bit of discussion in the last few years about a three-step technique, which essentially cover all of the surfaces, get your fingertips, and then do the thumbs, which, bear in mind, going back to the previous piece, were the areas that are missed most often. And there's been a number of papers on this, and then last year there was a review of all of the papers published in the American Infection Control Journal. The WHO are saying they don't have evidence yet that it is as effective as the 6-step process. But what a lot of people would say is, well, if I could get everybody to do the 3-step process all the time, that's better than some people doing the 6-step process some of the time. So it's under review. There's a lot of discussion, and some of the people who promote it, by the way, are in the WHO. So it's a valid conversation. So we go back then to the teaching methods, and we're still on the how here, and there's a bundle of them. There's classroom settings. So for a long time it was go into a classroom, put up the PowerPoint, take people off the ward as it might be, and then show it to them. There's obviously a lot of posters, depending on, back to my non-healthcare staff. There's various online training. So most national health agencies have some version of online training for hand hygiene. There's an increasing number of apps that are coming out. There's gesture recognition, which is what we use. There's VR headsets now. I think it's Torque have a program now with VR headsets, which is mostly aimed at the 5 moments, but does a little bit on the technique as well. And there's glow boxes, obviously, which I'll have a bet that everyone in this room uses glow boxes in some form or other, or has at some point in their lives. There are, I'm calling them advanced glow boxes now, which will sort of automate the process of seeing which bits are missed, record it, and put it into reports for you. But there's a bit of a problem, which is hand hygiene technique is what they call a psychomotor skill. And the educational experts would say to you, to learn a psychomotor skill, you have to practice, rest, and repeat. So you cannot learn it in one session. So we in Surewash did a study with Yale in the United States. And what we found was they had to go through about 32 attempts, which was across a 2-week period, of going through the process, having the camera on the computer giving them feedback as to how well they were doing before they hit proficiency. It was pretty strong correlation between the amount of time, the amount of sessions that people did, and whether they were proficient at the end of it. So it effectively was saying it's virtually impossible to learn it in one classroom setting or one session of anything. So we move on to the when. So obviously we have the standard WHO 5 moments. We have the adapted point of care 5 moments. We have the residential home 4 moments. So there's different variations. I mean, fundamentally what they all say is there are various times when you should wash your hands or apply gel through the course of your working day. That's the one where there's most discussion, most talk about compliance. And again, it's difficulty. So there was the recent IPS conference in Bournemouth, there was a paper presented, and it talked about reducing it to 3 moments. So there are efforts to simplify things. So we've potentially gone from 6 steps to 3 steps, 5 moments to 3 moments. And I actually like this. It's pretty simple. It's before care, during care, and after care. And what the paper was suggesting was that it was just much simpler for everybody. And when things are simple, they tend to get done. I think that's a little bit away, but it's a valid discussion. So where's the challenge with the when? Now this is where you could put 40 things up here. In terms of, I suppose, people being monitored and looked at, manual observation is very expensive and very time consuming. So there's a patient safety organization in the United States called Leapfrog, and they are very tied in with the people who pay for healthcare and the insurers. And they asked all of the healthcare settings to achieve their standard to do 200 observations per unit per month. And the APIC, which is the American Infection Control Study, kicked back after about a year and said, we just can't do this. I'll rephrase that. They said, we can't do this without buying electronic systems, and we can't all afford to buy electronic systems. So they've pared back a bit to 100, but it's still seen as a big challenge. And that, bear in mind, is in mostly acute hospitals with mostly open wards, not single occupied rooms. Time, and sometimes that time is well intentioned, you know, of I need to get to somebody quick, or I need to do something quick, or I need to move to the next piece. Lower interest, and that is related to, and there are a bunch of studies, and they all seem to say the same thing, that people are more compliant with using gel or washing their hands after they see a patient than before. And there's a little bit of an inference that that's about self-preservation or self-care. I don't know. You guys would know better than I would, and it might be worthy of a discussion that it could be more about I'm rushing to help a patient, and I don't take the time always. Then the skin concerns. I know during the pandemic there was a lot of new gel companies came on the market, and a lot of them were using the WHO basic formulation. They didn't have a lot of extra things in there to protect people's skin. So, you know, where somebody's using gel or washing their hands 100 times a day, the formulation of the gel becomes very, very important for the health of their own skin and themselves. And the last piece is the location of dispensers. So there's a bit of science, and there's more science all the time coming into that, to have the infrastructure right and to have the right type of dispenser, the right equipment in the right place so that it is easy to do what you need to do. So monitoring. As we said, the compliance levels are very low. Manual observation is expensive. There's a real trust issue with compliance, and staff generally don't like being watched. I think that's a general rule in life. There's a number of electronic systems that have been brought to Europe from the States, and they failed because effectively workers made them fail. So there was one where you had to recharge a little unit every night before you went home, or it didn't work the next day. Extraordinary many people forgot to recharge it. And I think it's fair to say that in Europe and the UK, there are not many hospitals or care homes using the electronic monitoring systems at the moment. But there's an awful lot of new systems coming out, and they're coming down in price. So it used to be you were talking about a couple of $100,000 and a major IT project to put a full-scale monitoring system into a hospital, and there wasn't really a scaled-down version for care homes, smaller residential units, etc. So the most basic ones just measure the dispenser. You know, how many times has the dispenser been used? The next level is ones that when you walk by, it will buzz or will make sure that you use the dispenser. Now bear in mind, the current systems mostly just check that you push the button on the dispenser or put your hand under it. You don't necessarily have to wash your hands. we're a good bit away from a full system like that. The more advanced versions then are the bed exclusion zones, where effectively there's a kind of an invisible ring around a bed, and if you go inside that ring without using the dispenser or the soap, your name badge goes red. And what that's really powerful for, and that system's out there, what that is really powerful for is patient pressure. So again, I go back to WHO a lot. Patients putting pressure on healthcare workers to wash their hands before they approach them. You see a red badge coming at you. It's like, woo. And to give you an example, there's a newish system in the States, and it's $475 per bed per year. It's a much simpler system than the previous ones and less expensive. And even from chatting to a few folks here today, the budget pressures in healthcare, and in particular in the care home sector, and trying to get investment for these kind of things is not easy. And trying to get the business case. So I'll talk a little bit about that later. So then we get to the last elements of the quadrant. So how well, there really isn't anything that I've seen that's imminent that's going to say before person A approached the patient or that they washed their hands correctly and that their hands are clean. And by clean, I mean clinically clean. There's another study that showed in Germany where 93% of people's hands were not clinically clean when they tested them in the hospital, but 60% of those people thought their hands were perfect. And the peer monitoring piece. So I haven't seen anything coming out from industry in the short term that's going to, for want of a better say, almost put your hands into something, bang, before you go to a patient. I think that's a few years away. In terms of the what with, the infrastructure piece is really important. What we're probably seeing more is, it used to be, how many dispensers do you need? And where are you going to put them? There's kind of an industrial design piece almost going on with soap and with dispensers to say, what type of dispensers do you need? Where do you need them in the building? And where suits. The dispensing systems are getting better. The other thing that comes up is hand size. And does a 7-foot tall man with huge hands need more gel than a petite 5-foot lady with tiny hands? And the answer is yes, but there's no simple way of doing it at the moment. So the dispensers tend to give out the exact same for everybody else. For everybody. Then obviously there's the efficacy of the gel and the soap. You know, I think all the major manufacturers would reasonably stand over the quality, and it tends to come down to price. What was interesting, the NHS did a tender. They actually published it at the very start of this year, and they haven't. It's a framework for hand care, hand hygiene. But they've included in the lots formally for the first time training and monitoring and all the bits. So it wasn't just a standalone, how many litres of gel can you sell me? And that litres of gel thing, just to give you an example, in France, up until recently, they were asking care homes to report on how many litres of gel they used a month. That was the only way they could think of saying, is there enough hand hygiene going on in your various centres? And obviously the formulations are important to the workers. But they're important as well because if workers think, whether they're correct or not, that too much gel or too much soap is doing them harm, they'll avoid using it. So the last bit that I put on that quadrant is the reporting piece. And what we're seeing more and more and more, and we came under pressure to do, and anyone who works kind of in the industry is reporting. So this data piece. And of course, if you have to create reporting, that becomes an industry in itself. So, you know, if you're going around doing training and then you have to manually write up training reports or input things to Excel, but it is definitely, everywhere we look, higher requirements for reporting. And also ways to import it to a hospital's training records. So a lot of big organisations, and a lot of smaller organisations now have got some kind of learning management system or HR system where they record. The example I would use is manual handling training. Has everybody had their manual handling training, and is there a record of it? Well, the same is applying now for hand hygiene, with proof. But a lot of the reporting is around the compliance with when, as opposed to how. So, in terms then of this, WHO is actually the word who, as opposed to WHO in this example, and who obviously needs to train, and there are variations. So, massive focus on healthcare workers, slightly less focus on other staff who come in and out of healthcare facilities. I think particularly in the care home sector, patients and long-term residents. It has been said to me it's a great stuff for activity managers to do if they can find a fun way to do it with training residents. And I suppose again, difference from acute hospitals is, visitors and patients tend to be much longer term, and therefore training the visitors so that they know what they're doing also becomes important. And then my favourite one is management. There should be no CEO or managing director of any healthcare facility anywhere in the world who doesn't know how and when to wash their hands and hasn't published it heavily to their staff. And if they are, I think they should be asked the question. I really do think it's a great thing. Robert Jones Agnes Hunt Hospital in London, their board chairman came down, he got the entire board to train in our system and sent out pictures of them all doing it, so all of the hospital saw that it was being done. But I would wonder how many of your various organisations, CEOs, have exposed themselves, because obviously there's a risk as well if they fail, have exposed themselves and have shown that leadership. So, all in all, anything I've said doesn't take away from the fact that hand hygiene and the multimodal approach is effective in improving things. And hand hygiene itself, of course, is only one part of wider infection control. The people in Leapfrog, the patient safety organisation, they have a big mantra which is make it stick. So they say they see lots of short-term interventions, Global Hand Washing Week, World Hand Hygiene Day, it's great. And then it just drops off as people get busy and as other priorities take over. And I go back to what I said in the first slide. And as I suppose a layperson you'd call me, clean hands save lives. How simple is that? And how hard is it to get people to do it? And what I hope is the positive message for you folks is in some of those numbers I put up earlier is if you think you're not doing great, you're like everybody else in the world. It really is a struggle, this stuff. So future developments that are coming. The UK Health and Safety, the HSE, are, my understanding, getting a bit more fixed on the organisation's duty of care to their staff to protect them from hazards. And obviously training is a key part of that. Now, almost all of these things should help with a business case to invest. So the other thing I get everywhere I go in the world is I would love product A, or I would love product Y, or I'd love to be able to do this, but I find it very hard to get the budget for practical infection control measures. The increasing external scrutiny and reporting really helps because, back to CEOs and hospital boards, when there's external scrutiny and external reports, they tend to get more interested. The mandatory reporting piece, that's really helpful for a business case because when something has to be done, instead of saying, I want to do this to train someone to wash their hands, to train them on wider IP, I want to do this to tick the box that we have to tick as an organisation is helpful. There's a new ISO standard coming out for hand hygiene, so organisations that want to have the latest ISOs, that should be out in spring of next year. It's currently in its final stages. The combining technologies and the reduction in the cost of technologies. So there isn't much doubt in my mind that a lot of the stuff that's currently out of reach of the care home sector will be within reach within 3-4 years. And some of that's happening quicker than others. And complete solutions. I think in the future, what you're likely to have is you won't be buying gel off one company, you won't be buying training, you won't be buying monitoring, you won't be buying dispensers. It's to actually push industry, and you guys can do that as well, to put together a complete solution that you go to one person and say, I would like a solution for hand hygiene that encompasses all the bits that I need to do for it. So that's hopefully been reassuring in some ways, maybe frightening in others, and gives you a little bit of flavour of some of what is coming down the line.